Good evening. Now today we are going to check and tackle the MCQs that you did on reproductive health, courtesy of medical students around, and this is OUMA presenting. Now, the first question was, which type of twin pregnancy results from the fertilization of a single ovum? Now, which type of twins pregnancy arises from the fertilization of a single ovum? So we have dizygotic, monozygotic, dichorionic, multifetal gestation. Now I'll discuss and I'll tell the answer. So the answer here is going to be monozygotic. Now what is a monozygotic twins? Monozygotic twins, they're also known as identical twins, developed from the fertilization of a single ovum by a single sperm. So single ovum, single sperm. When two ovums have been fertilized simultaneously with the two different sperm, that is a different case. It's not monozygotic. So it's not the identical twin. So after fertilization, the zygote undergoes mitotic division. At some point during early embryonic development, it will split into two genetical identical embryos. So because the original, they originate from the same zygote. Monozygotic twins share the same genetical material. So they have even the same sex, same blood type, and identical DNA, except for minor epigenetic variation that you can consider getting. So the degree of placental and amniotic sac sharing depends on when the zygote split. When the zygote split is when that placental and amniotic sac sharing can come in. So option B is the answer, that is monozygotic. Dizygotic is the other one. Dizygotic is a different case. So monozygotic twins result from the fertilization of a single ovum. A single egg, a single sperm fused to form a zygote. Then the zygote split into two embryos, leading to genetical identical twins. Depending on when the split occurs, they may have separate placentas and amniotic sac. That is what we call now dichronic diamniotic or di-di, okay? Dichronic, that is when they have separate placentas and amniotic sac. When they share placenta but separate sac, we talk about monochronic diamniotic. But when they share placenta and they as well, share amniotic sac, we call about monochronic and monoamniotic. That is MOMO. So we have di-di, we have MODI and MOMO. So di-di is same placenta, same amniotic sac. MODI is shared placenta but separate sac. Okay, shared placenta and amniotic sac, that is MOMO. So let's check about the other options. Dizygotic twins, it's very incorrect because dizygotic twins result from the fertilization of two separate ova. So it occurs when two different eggs are released during ovulation and fertilized by two different sperms. And these twins are genetically unique, like any siblings, and may be of different sexes as well. So always have separate placentas and amniotic sac, and therefore they are always dichorionic, and diamniotic as well. So dizygotic twins arise from two ova, not one ovum. So that is not the answer. Okay. Dichorionic twins, that is incorrect. Okay. Yeah. Because that when you see option C is dichorionic twins, we don't have that one. We only have dizygotic twins and monozygotic. Dichorionic is very incorrect. Why? It refers to placental structure and not zygosity. And then dichorionic twins can be either monozygotic or dizygotic. Okay. But we don't have a twin called dichorionic in particular. So, okay, so a monozygotic twin split occurs only before day 3, I think, and they will have separate placentas. Now, all dizygotic twins are dichorionic because they come from separate fertilized ovum. Multifetal gestation, very incorrect. Multifetal gestation refers to more than two fetuses, not a specific twin type. And a multifetal pregnancy include triplets, quadruplets, and higher order multiples. So multifetal gestation is a different thing. It may result from combination of dizygotic and monozygotic process. So it's not any way definition of a twins. So that is that. So what I've concluded on that question that the answer is monozygotic twins. They are very unique. They result from fertilization of single ovum by a single sperm, genetically identical, that is same DNA, same sex, and same blood type. The degree of placenta and amniotic sharing depends on when the zygote splits, different from dizygotic twins, which come from two ovums. So the answer is B. I hope you are good up to there. The second question, which of the following condition is associated with polyhydramnios, that is excess amniotic fluid? I hope you, yeah. So which of the following conditions associated with polyhydramnios or excess amniotic fluid? We have maternal hypertension, diabetes mellitus, fetal renal agenesis, oligohydramnios. So let's start with detailing each of them. So first of all, mostly we get polyhydramnios, excess amniotic fluid. You know, we have oligohydramnios. This one is all to do with the amount of amniotic fluid. There's some measurement in terms of given unit that will give us indication of polyhydramnios. So the answer here is diabetes mellitus or mellitus, okay? What is polyhydramnios? Polyhydramnios refers to excess accumulation of amniotic fluid in the amniotic sac, which is at most defined as amniotic fluid index above 25 centimeters or deepest vertical pocket over 8 centimeters. So amniotic fluid plays a crucial role in fetal development, aiding in lung maturation, movement, and protection. So the balance of amniotic fluid is maintained by fetal swallowing and urination. Any disruption in this balance can lead to polyhydramnios or what we call oligohydramnios. Poly when it's a lot, oligo when there's too little fluid. So why diabetes mellitus? Because maternal diabetes, especially poorly controlled one, what we call even gestational diabetes or pre-gestational diabetes, is a leading cause of polyhydramnios because we'll have things to do with fetal hyperglycemia, that is a uncontrolled maternal diabetes. Diabetes leads to excess glucose crossing the placenta, that is now fetal hyperglycemia. We have fetal polyuria. The fetal experiences hyperglycemic, leading to osmotic diuresis, resulting in excess urine output and increased amniotic fluid volume. That is, we'll have macrosomia, that is increased fetal activity due to macrosomia is just large in size. Okay, so excess glucose also leads to fetal macrosomia, that is large baby, which may impair fetal swallowing, and therefore we'll have further exacerbating fluid accumulation. So other conditions associated with polyhydramnios are like congenital anomalies like neural tube defect. I know you know about the spina bifida or Carlton cystica. I hope you know about them. The cardiac malformations. They are more common in diabetic pregnancy, contributing to polyhydramnios. So fetal respiratory distress syndrome can develop due to preterm labor, a risk in polyhydramnios as well. So just to conclude, diabetes mellitus causes fetal hyperglycemia, leading to osmotic polyuria and polyhydramnios as well. So why the other options are incorrect in this case? Just incorrect. Well, we have maternal hypertension, very incorrect, okay? Because it is not. It can come along with oligohydramnios, but not polyhydramnios. And hypertension, like gestational hypertension, preeclampsia, chronic hypertension, all these ones, they lead to uteroplacental insufficiency, but not in any way related polyhydramnios. So this reduces fetal urine output, that is maternal hypertension, leading to decreased amniotic fluid, causing oligohydramnios rather than excess fluid. Okay, fetal renal agenesis. Fetal renal agenesis leads to oligohydramnios, not polyhydramnios. And fetal renal agenesis means absence of fetal kidneys, leading to anuria, that is lack of urine production. So since fetal urine is a major contributor to amniotic fluid, its absence causes severe oligohydramnios. Classic example in Porter syndrome. I know you know Porter syndrome, where we have bilateral renal agenesis. We have pulmonary hypoplasia and fascial abnormalities as well. So just in general, without fetal urine production, amniotic fluid volume decreases, causing oligohydramnios and not polyhydramnios. Okay. Similarly, oligohydramnios is the opposite of polyhydramnios, so it's also incorrect. So that is also diabetes mellitus causes polyhydramnios. So polyhydramnios results from excess amniotic fluid accumulation, and maternal diabetes leads to fetal hyperglycemia and osmotic diuresis. Excess fetal urine contribute to polyhydramnios, and other causes include fetal congenital anomalies, Yeah, in diabetic pregnancies. Okay, so that is the answer. We have, what is the most fertile period in a regular 28-day menstrual cycle? A, days 1 to 5, B, days 7 to 10, C, days 12 to 16, D, days 22 to 28. The question is, what is the most fertile period in regular 28-day menstrual cycle? Now we can have irregular, people who have irregular menstrual periods. So we are talking about the regular 28-day menstrual cycle. So the correct one is day 12 to 16. Now, menstrual phase, we have day 1 to 5. Follicular phase, we have 1 to 3. That is if you talk about the menstrual cycle, divided into 4 main phases. We have the menstrual phase, follicular phase, ovulatory phase, and luteal phase. So menstrual phase, follicular phase, ovulatory phase, and luteal phase. So menstrual phase, I've said it is day 1 to 5. Follicular phase, day 1 to 13. Ovulatory phase is day 14. That is in the 28-day cycle. And luteal phase is day 15 to 28. So let's talk about the menstrual phase, which is 1 to 5, shedding of the uterus lining in no fertilization occur in this one. Follicular phase, estrogen stimulate follicle development in the ovary. Ovulatory phase, the luteinizing hormone surge triggers ovulation, releasing an egg in the ovary. And then the luteal phase, 15 to 28, the corpus luteum secrete progesterone to prepare the uterus for implantation. And if that fails, the cycle starts again. So why days 12, 16 is the most fertile period is because the fertility window, the fertile window is the time frame when a woman has the highest chance of conception. And ovulation typically occurs on day 14 in a regular 28-day cycle. But a sperm can survive in the female reproductive tract for up to 5 days. So when the egg remains viable for up to about 24 hours after ovulation, so you see that is still a trick. So the fertile window is from about 5 days before ovulation, let's see, day 9 to 10, to about 1 day after day 15, that is 15 to 16, after day 14, that is 15 to 16. So it is 5 days before, that is 9 to 10, okay, and then 1 day after the ovulation. So the peak fertility days are day 12 to 16, and when both sperm survival and egg viability overlap, increasing the chances of conception. So that is that. So day 1 to 5, there are say menstrual phase, 7 to 10, early follicular phase, luteal phase is 22 to 28. So that is that. Let's check the second question. The third question. Which virus is most commonly associated with cervical cancer? We have hepatitis B, Epstein-Barr virus, hepatitis B, Epstein-Barr virus, human papilloma virus, and cytomegalovirus. So which virus is commonly associated with cervical cancer? Okay, I know this one, you know. It is human papilloma virus. Everybody knows this. So what is HPV? What is this human papilloma virus? It's a sexual transmitted DNA virus that primarily infects epithelial cells of the skin and mucosal surface, including the cervix and the genital tract, oropharynx, and respiratory tract. So HPV is the primary cause of nearly 99.7 cervical cancer cases worldwide. And you know how it causes. We have high risk HPV type, especially HPV 16 and HPV 18. You should know that they reproduce viral oncoprotein, that is E6 and E7, which inactivate tumor suppressor protein, that is P53 and RB, leads to uncontrolled cell growth. So they disrupt normal and cell cycle regulation, increasing the risk of DNA mutation. This promotes persistent infection and cervical dysplasia, then that will progress to cervical intraepithelial neoplasia, that is CIN, united by CIN, cervical intraepithelial neoplasm, and eventually cervical cancer. So HPV and cervical cancer rates, we have HPV 16 and HPV 18, responsible for about 70 of cervical cancer cases. HPV 31, 33, 45, 52, and 58, they cause additional 20% of the cases. Low risk HPV are like HPV 6 and 11. So that is that. So prevention strategy for HPV cervical cancer, HPV vaccination, like we have Cervarix, Gardasil, and Gardasil 9. They provide protection against high-risk HPV strain. And regular pap smear and HPV testing detect precancerous changes in CN1 to 3 allele. So just safe sexual practices like condom use, limiting sexual partners reduces transmission. So why the other options are incorrect? Hepatitis B virus, that is nothing. You know that very well because it's not linked with the cancer, it's linked with liver issues. Can be liver cancer, but not cervical cancer. HBV, that is hepatitis B virus, will increase the risk of hepatocellular carcinoma. Okay, the HCC due to chronic liver inflammation, and it's blood-borne virus, not a direct cause of cervical cancer. Okay, we have Epstein-Barr virus, HBE, we call it EBV, is a link to other malignancy, not cervical cancer. So EBV is associated with nasopharyngeal carcinoma, the Burkitt lymphoma, Hodgkin lymphoma, and some gastric cancers. So it is actually transmitted through saliva, kissing disease, not a primary cause of cervical cancer. Talk about the cytomegalovirus, does not cause cervical cancer. Cytomegalovirus is a herpes virus that causes congenital infection and opportunistic infection in immunocompromised patients like HIV patient. So there's no that strong evidence linking it to cervical cancer. So that is that. Let's see the number 4 question. Which hormone is used in hormone replacement therapy, the HRT, to prevent osteoporosis in postmenopausal women? We have estrogen, A, B, progesterone, C, androgen, and D, cortisol. So talk about estrogen. Yeah, we want to see. So the answer here is estrogen. Estrogen is the one which is used. Okay, so hormone replacement therapy to prevent osteoporosis in menopausal, we have estrogen. So what is osteoporosis? That is one thing. Osteoporosis is a progressive bone disease. Actually, it's always characterized by low bone density, increased bone fragility, and higher risk of fractures. It is particularly common in postmenopausal women due to decline in estrogen levels after menopause. So how does estrogen prevent osteoporosis? Estrogen plays a crucial role in maintaining bone density through several mechanisms. They inhibit osteoclast activity. Osteoclasts are cells that break down bone, and estrogens suppress osteoclast function, reducing bone resorption. So they also enhance what we call the osteoblast function. And the osteoblasts are bone-forming cells. The estrogen helps maintain osteoblast activity, promoting bone formation. They also help in maintaining what we call calcium homeostasis. Estrogen increases calcium absorption in the intestine and reduces calcium loss through urine, maintaining bone mineral density, the BMD. So that is that. So why the other option correct, like progesterone is used in HRT but does not directly prevent osteoporosis. Okay, so it's not a significant role of it. Androgens like testosterone do not influence bone health, but they are not the primary HRT choice for osteoporosis prevention. Okay, and many others like cortisol, incorrect. Cortisol is very incorrect. Why? The glucocorticoid substance actually causes osteoporosis. So chronic high level of cortisol such as in Cushing's syndrome, or a long-term corticosteroid use increase bone resorption and decreases bone formation. And this cortisol will now reduce calcium absorption and increase urinary calcium excretion, worsening bone loss. So that is that. Second, the fifth question. Read the fifth one, then we'll continue from then the next time. Monochronic monoamniotic twins are at high risk of which complication? Twin-to-twin transfusion syndrome, preeclampsia, placenta previa, and anemia. Which one is which? Monochorionic and monoamniotic twins are at high risk of which complication? Twin-to-twin transfusion syndrome, preeclampsia, placenta previa, and anemia. So that is twin-to-twin transfusion syndrome. It was actually direct. So twin-to-twin transfusion syndrome, twin pregnancy can be classified based on the chorionic CT or amniotic, and I had already discussed that when we were discussing about the dizygotic and monozygotic. Dizygotic and monozygotic. So chorionic CT, number of placentas, amniotic and number of amniotic sac. Mono, di, they are separate, okay? So we talk about monochorionic, monoamniotic, that is MCMA. Twins develop when a single fertilized egg split between days 8 to 12 of fertilization, leading to one shared placenta. and one shared amniotic sac. So what is twin-to-twin transfusion syndrome? Is a severe concern that occurs only in monoclonal twins due to abnormal blood vessel connection in the shared placenta. So pathophysiology, like blood vessels in the single placenta, will form a vascular anastomosis. Anastomosis is just like a branches of the same to aid in the supply of the blood. So they lead to unequal blood flow between the twins. One twin, the donor twin, loses blood volume to the other twin, which now receive. Complication of TTS, like the donor twin will reduce blood supply, so will have anemia, therefore growth restriction, oligodominance, amniotic fluid, will have hypovolemia, organ dysfunction, risk of fetal demise. Recipient twin, excess blood supply, polycythemia, volume overload, polyhydramnios, and cardiac strain, heart failure, and hydrocephalus. So those are the things which are very okay. Why are the MCMA twins at a high risk? Because they will be sharing placenta and amniotic sac, and they have increased risk of vascular anastomosis. Okay. So preeclampsia, no. High blood pressure and with organ dysfunction in pregnancy is not common in twin pregnant. Placental previa as well. Okay. Risk factors of placenta previa like the previous cesarean section, multiparity, advanced maternal age, smoking, but not that. Okay. So I will stop this at there because I'm already at 20 minutes. I will post it in YouTube and I'll share it as well in the groups.